Hello, good evening to everyone. Thank you for joining me for what should be another one of these fascinating interviews. I have interviewed Sean and Jennifer different times and together once, and every time I speak with them, I am inspired by their position, their integrity, their knowledge, and everything that they stand for. We need people like this to help to guide us through the mire that most of the public. We have huge challenges to face. And our hope now is that through this kind of discussion, which will be open, frank, honest, we will start the road of trying to rebuild some degree of integrity. Before we start, just a reminder for everyone that coming up in the next week or so is our conference, one of our first conferences in a while, Hidden Drivers of Post-COVID Dysfunction. It is a major headline presentation with a number of experts, and some of our panelists join us at the link that will be there below and join us in this process. So thank you very much for that. So without further ado, let's get straight into our wonderful presenters who are with us today, Jennifer and Sean. I will start off with Sean giving us a quick introduction of himself. Sean, can you introduce yourself? And then I'll ask Jennifer to do the same.
Absolutely. Thank you, Dr. Philip, and good afternoon or good evening or even good morning to some of those out there listening worldwide. I do want to thank you, Philip, for having me today on the show. My name is Sean Kaufman. I'm CEO and founding partner of Safer Behaviors, and I have about 30 years of public health experience, primarily dealing with infectious disease and health education, health promotion, and emergency response. So again, Philip, it's great to be here. Thank you for having me.
Wonderful. And Jennifer?
Hi, Philip. Hi, Sean. Thanks for having me back. It's always good to chat with you. So I have a PhD in microbiology and molecular cell sciences with subject matter expertise in virology, specifically respiratory viruses. I spent my career working in research with mainly influenza. I've worked with other respiratory viruses. I've managed government contracts to test candidate vaccines for hemorrhagic fever viruses. And most recently, I worked as an epidemiologist at the Hawaii Department of Health, where I worked in disease outbreak control division. I served as the influenza surveillance coordinator and was on the front lines of the pandemic doing case investigations and contact tracing.
Wonderful. Now, as we start, I want you to do something for me, Sean, especially with regards to what is happening in the USA, where a lot of people from the scientific community are shouting from the rooftops that there is targeting of public health professionals that have been involved in the major organizations, CDC, HHS, FDA. What exactly is happening on the ground to help us to understand that a little bit better?
No problem. So I think for the most part, we got to keep in mind that there are multiple things happening at the same time. The biggest thing that's happening, though, Philip, is there's what we call a reduction of workforce. And so probably a couple months ago, there were several federal employees that were asked if they wanted to take what we call a fork in the road. Knowing prior to that reduction of force, if they were to elect to leave on their own, they would receive roughly about 9 months of free pay, and they would get paid for 9 months, but they would elect to resign their positions and they would elect to leave, and it would be kind of some type of payout that the federal government would get to have people self-elect to leave the workforce. Now, there have been specific targeting, meaning there's offices and locations within the government that have been shut down, people that have been forced out of a job. But that's currently what is happening right now. It's kind of a mix of both. It's not one thing or another, but I would say majority of the people that are exiting the public health workforce are exiting having an offer. We call it kind of a fork in the road, so to speak. And they're choosing or electing to take that and self-identifying and leaving. Otherwise, what they'll do is they'll face what we call a reduction of workforce, which means they'll get nothing. Meaning, if their name is on a list and they are reducing the workforce, their name will be listed. They'll be kind of escorted out of their job, and they'll lose their job. So it's kind of a phased approach, so to speak.
You know, I think I'd like to get Jennifer's thought on this because, Jennifer, you were in a position where you were working with government, epidemiology, early in the pandemic, and your actions of challenging leadership caused you to lose your job. And it had a huge impact on your life. When you consider what is happening now for all those people who were willing to remain silent when there were probably things they could or should have spoken out about, how does it make you feel now when you see almost something in reverse happening?
It's interesting that you're bringing this up because this is actually the 4-year anniversary of my being discharged from my position with the Hawaii Department of Health for blowing the whistle on their corruption and lies. So, you know, this past few weeks I've been very angry. I've been very angry about that because there is no justice for whistleblowers. There's no justice for people who speak power to truth. So I have mixed feelings about what I'm seeing with the government reduction in force, because I feel like in some ways there are people who do need to go. But at the same time, I think that there's probably a better approach that could be taken in terms of who's more significant to lay off versus, you know, just doing this. It seems kind of willy-nilly. So they apparently have fired all the probationary employees. This is my understanding from what I've seen in the news, but I think it should be more of a top-down approach because, as you said, there were people there who've been there for a very long time, and there are people who've been there for 20, 30 years, and they're the reason that there's a systemic failure of public health. And so why would you get rid of the new people who are coming in? I feel like those are the people that you should keep on and train them in the way that you want the new direction you want the agency to go, instead of getting rid of the people who are just new. I think those are the people that you have an opportunity to train and to influence and to actually have some correction in the direction and mission of these agencies.
You know, I when I think about it and I reflect on what is happening in terms of trust for public health, I've seen it happen for doctors. Their trust dropped from 71 to 40% in the 4 years from 2020. I can imagine it may be worse for public health. I believe that probably one of the most important things that is needed now is integrity, even more so than being the best in the field. I think it needs to be people of integrity. Sean, could you expand on that idea for me?
No, absolutely. And I wanted to add to something Jennifer said. I agree 100%. I think the reduction of the workforce, look, I'm an expert witness on a particular court case where something that happened to Jennifer happened to an individual, and they are in the middle of a lawsuit. And when I was asked by the individual in the court case, I was doing a testimony for these individuals, and I met them before I did that so I could understand their work environment. And the individual asked me how I was doing, and I said, well, it's a pretty tough day in public health. I have a lot of good people, as Jennifer has brought up. There are lots of people that have lost their jobs. Some of them should. They should have exited the public health workforce a long time ago. But some of them are the up and coming future leaders, Philip, and some of them are just amazing people, and they are out of a job now. And when I said it's a dark day in public health, and when I say it's a bad day, he replied to me saying, good. And I said, whoa, what do you, I didn't expect that. He said, I hope public health loses all their jobs. I hope all of them lose their jobs. And he said, you want me to recognize it's a dark day for public health, but where were they for me when I was losing my job? Where were their voices? And I said to him, I said, I've always been involved in this case. He says, yeah, but Sean, majority of them, they didn't speak up for me. And so when going back to your question and what Jennifer had said earlier, I do believe that the reduction of public health workforce should be looked at and be more of a strategic cut. We're going to strategically look at people based on merit, based on how they're performing, versus kind of a global cut. We're just cutting divisions, cutting offices, so to speak. So it can be more strategic. But you're right, Philip. Now more than ever, we need leadership. And part of leadership means integrity. And when you're working in public health, you're not championing an agenda, a certain politic. You're championing for the people. And I think that that's what we need most right now in public health is a leader with integrity that does that.
Well, it takes us right into the issue or the question with RFK. And I must admit, when he was put into that position, I thought that this was a good thing. I thought that there needed to be a change, a fresh approach to what was happening. But I do recognize the risk. And the risk is that he goes too far with what he's thinking. And my worry is that he doesn't surround himself with the expertise that he needs, one, and with people who are not completely in agreement with him. In this situation, you need the people to challenge you. Jennifer, any thoughts? What is your feeling now with regards to RFK? What should he be doing? Where should his focus be?
So I think that part of having integrity means that you stand up for what you believe in. So he has been very vocal over his career about certain things. And, having integrity means that you stand by what you've said. So I said it, I meant it, and I'm going to stand by it. And I'm going to continue to, continue with that agenda. And I think that what he said in terms of vaccines, he gets labeled anti-vaxxer all the time. And it's frustrating for me because I get that label too. As somebody who worked in vaccine development, it's frustrating. And I don't understand why people would be upset about wanting fully robustly tested products that they're going to be injected into their body. So what he has always said is he believes in vaccines, but he just wants the science to back them up, to show that they are effective, to show that they are, I don't like the word safe because safe is really not scientific. What we need is toxicity testing. Let's show toxicity is a spectrum. Okay, so nothing's going to be 100%. And I know they use safe and effective because it's a great marketing campaign, has a great ring to it. But the scientific word is toxic. Is it toxic? Is it non-toxic? Where is it on the spectrum in terms of toxicity? And that is key. And I think that's what he's really been pushing for, is more studies to look at that in terms of vaccines. So, if this is what you said, then stand by it. Then that's what you need to do. You need to stick with your agenda and not be swayed by any outside influences.
And when you think about that, Sean, when you see that he has his own personal views, his own personal agenda, you guys have been working with vaccines for a long period of time. You must recognize that there is now a risk that all of the trust and faith the public had in vaccines as a whole could be damaged, whether or not it's for the good reason that he's concerned about, toxicity and so on. Is it worth it?
Wow, what a great. So, Philip, before I get into vaccines, let's talk about, RFK in public health. This country spends more money than most countries do on health and healthcare than most countries do around the world. And yet we have some of the worst health outcomes in the world. In fact, I don't mean to be advertising for an app called Yuka, but I use Yuka often in every single shopping center I go to look at the food products based on the European standards, to see what Europe has banned and what the US allows for their consumers to continue to eat. And one thing that really frustrates me is there are a lot of people that complain about RFK, say he's unqualified, say that his reform ideas are extreme. But how can you argue about changes in a system that has completely failed its people? We spend so much money on health and healthcare and outcomes, and yet we have the least healthiest of all developed. It's absolutely horrific to even talk about that. Now, vaccines are one of his items, and if you notice and you listen to him very, very carefully, it's not necessarily that he is against people receiving vaccines. He's against people being forced to take them without having a choice. He has an opinion on vaccines. Quite honestly, I think he's missing it. He's focusing on measles. I believe hepatitis B is kind of the bigger one, where you vaccinate a baby within the first 24 hours of their life. And I don't like that idea. We could talk about that later, but I think that's only one of his agenda points. I think he's trying to identify that in this country, Americans are exposed to things that Europeans are not exposed to. We have access, issues. We have health literacy issues in this country, and I think to be a reformer, he's going to have to attack what we typically have said is taboo not to talk about. And I think that's what he's doing. He's starting his platform off very strongly.
And Jennifer, there's a comment that was made here that I want to put in front of you. It's hard to know who you can trust in the medical field anymore. And this, I guess, also represents in terms of public health. How do you answer that for the public?
Well, I know these 4 words kind of upset people sometimes, but do your own research. Don't take the person in the lab coat's word for it. So, I've always told people, even for myself, when I go to the doctor, I would say, okay, I will take that under advisement and then let me go look into it. So I will get back to you. You don't have to make that decision. You don't have to get that shot that day in that office at that time. You don't have to take the prescription. You don't have to go back home. There's this great thing called the internet. There's lots of information out there. Talk to other people, get a second opinion, get a third opinion. There's no reason why. There's no reason why you can't vet this information. There's no reason why you can't get more before making a decision. There's simply no reason for that. We have so much at our fingertips that we can look into. And, it's really interesting. I was doing some work for my colleague in a case, for toxicology case. And I told her, I was like, I've worked in vaccine development and preclinical testing, and I've largely really not paid attention to vaccines because, well, I don't have children, so I haven't had to really think about rotavirus vaccine or PCV or HPV vaccine or any of those, because it's just not something that's in my sphere right now. And so I started digging into some of these for this case, and I was shocked. Just read the package insert. I was floored. If you look at the vaccine package insert for some of these vaccines, all the information is there. This is clinical trial data and studies that the manufacturer did, that the FDA has reviewed, that the FDA has used to approve these things. It's all right there in black and white. It's easy to find, and you can read it for yourself, and then you can make those decisions.
Well, I think that one of the big challenges that RFK is facing at the moment is this issue with the measles outbreak. And one of my thoughts on what is happening is that we're having a problem outside of the measles situation. I think this is population immune suppression, but that's just my thought. However, he's under a lot of pressure from a public health point of view to promote the MMR, the measles vaccines at this point in the unvaccinated cohort. When you think about what's happening, because measles can be a serious disease, if you were talking to him or if you were sitting in a meeting with him, what would you be saying to him at this time?
Well, I believe Garrett's refrain on this is pretty poignant at this point. Is you don't vaccinate in the middle of an outbreak. You simply do not. I am shocked that anyone would take a live virus vaccine while the field strain of vaccine or virus is circulating. Especially, they're telling people here, which is very interesting since I'm in Texas. Why would you recommend, if someone's been exposed to the virus, to go get the vaccine, which is a live virus vaccine? As a virologist, I understand the implications of that. You know, there's a risk for recombination and mutation with the field strains. There's too much risk right there. I actually called the Texas Department of Health because I was like curious where this recommendation came from. What clinical studies were they basing this recommendation on? What peer-reviewed journal articles were they basing this recommendation on to get a MMR vaccine prophylactically? And you know, I'm going to tell you, the person that I talked to was me at the Hawaii Department of Health. I was that person sitting there answering these phone calls and not knowing what to say. And, oh, she told me she would take my number and get back to me. And I never got a return phone call. So I think it's very dangerous. I think it's very dangerous when you don't understand vaccines, you don't understand vaccinal immunity, you don't understand viral evolution to make certain recommendations. So you really need to think a little bit more about the implications of what these recommendations are.
And your thoughts, Sean? What would you say?
Well, see, Philip, the one thing that Jennifer had mentioned earlier, you know, when I grew up, we were lucky to have encyclopedias in the other room in the debate that we would be having at the table. Today, we can ask Google or Alexa or Siri, and within 30 seconds, the debate is over at the table. And what scares me about that from a behavioral standpoint, which is really my background, is that we've become information consumers instead of information predators. And what we mean by that is instead of going out and hunting for information, just like what Jennifer just talked about, she's a virologist, and she just talked about the live strain virus being used in the middle of a potential epidemic with field strain measles cases. Why that is an issue, why that is a serious issue that people should understand and know more about. You have to be an information predator, which means you have to actually go out and seek arguments for and against a particular behavior, look at the sources, be able to listen to both sides, and then as an informed consumer, make the decision that's best for you and your family. And that's where I come in on your question to me. Again, as a public health professional, it is not my job to tell people what to do with their bodies. It is my job to give them information and then empower them to do what's best for them and their families. And that means that I'm not serving an agenda. I give them both the strengths and weaknesses of a particular vaccine, and then I ask them to make the best decision that they can with what they have. That to me is an important aspect. The serious, like you said, with measles, most cases in measles, if you are a healthy individual, most cases of measles is not going to be lethal. You'll earn your immunity the way that we used to. I got chicken pox from playing with a kid that had chicken pox, and then I had to give to my brother in that way. We earned immunity back in the day before vaccination. So I would look at the seriousness of disease. I would look at your current health state. I would look at the current vaccine. I would look at the current state of the environment in which you're living in. Is there an epidemic? Is there not? I would talk to folks like Jennifer, folks like you, and then I would make a decision that's best for me and my family. Again, never my job as a public health professional to tell people what to do with their bodies.
Well, the question seems to be is that public health has taken the perspective that things need to be black or white. And this is not just in the US. This is broadly across the world, where it is you do something or you don't do something. You mask or you don't mask. You vaccinate or you don't vaccinate. It's that kind of thing.
Right.
Jennifer, you defend that approach. Why is that the case? Is it that they don't believe that the public can understand the nuance?
So during the pandemic, I had this conversation with one of my coworkers who's a PhD epidemiologist. And I was like, you know, this doesn't make any sense. And he said, you know, it's just easier to it's easier to just give a blanket statement and tell everybody to do the same thing. rather than try to explain the nuances to everybody. And that does to me smack of like, well, they're not smart enough to understand. And I found it interesting because I found out from I don't remember who I'd spoken to, but in India, let's talk about masking. Everybody wear a mask, right? 2-year-olds wearing a mask, that makes no sense. Why are we wearing masks when we're outside alone? Why are we wearing masks in cars? In India, the children there in India understood that masks were to be worn in crowded spaces. When you're outside, there's no reason for a mask. When you go inside in a crowded space, that's when you put a mask on. And I thought, well, maybe we need these children from India to come here and explain it. It's kind of a funny, but I think that attitude is really kind of sad, especially because from my experience, public health is sitting in an office behind a computer screen. They've lost touch with the actual public part of public health. Get out in the public. Get out and talk to people in the public. You need to make those connections and relationships, build those relationships with people in the public. Those are the stakeholders. Those are the people you're working for.
It seems as though there's now a silence from public health. And I don't know if it's that they have been told to be silent or because they genuinely are completely lost and not sure what to say, and they are afraid of being wrong anymore. Because this is one of the things that we've seen is that, every prediction seems as though it has gone haywire. And after a while, people start to lose confidence. But Sean, what must they be feeling and thinking?
Well, I think, Philip, there is a distinct difference between the public health professionals and the public health leadership. And I can't speak for the world. I can speak for what I'm familiar with here in the U.S. And I can tell you, it is my opinion that the public health system here in the United States is broken. And the leadership, if you look at who appoints the public health leadership in this country, NIH, CDC, it's the U.S. president. Presidents change every 4 years. Usually, sometimes the agendas change depending on what party an individual's in. Not only is that the case, but when you look at lobbyists and you look at businesses, just in 2022, we look at pharmaceutical companies making $1.4 trillion in this country. And we look at healthcare companies in this country making $4.3 trillion, meaning healthcare is a business, big pharma is a business. Those lobbyists, individuals influence our congressional elected staff by throwing parties and putting them into power. You've got presidents that have political agendas who appoint the public health leaders of this country. And you have individuals who are in public health trying to do the best they can. They're not leadership. They're just public health professionals who, like Jennifer, I mean, my heart goes to her. She is a educated, strong, passionate public health professional. She spoke her voice. She should have never, ever been removed or treated the way that she was treated because she did not agree with the agenda that was being pushed during COVID. And so I think people saw people like Jennifer get fired and terminated, and they've got mortgages, kids in college, and quite honestly, they prefer a comfortable life versus a life that says, listen, what we're doing is wrong and I don't agree with this. Very few people, Philip, very few people are like you. You have stood the test of time. I have watched you take a lick from the left, the right, up and down and all around. And I know it may seem normal to you, but very, very few people put it on the line like you do and like Jennifer has. So you both deserve huge accolades for that.
Yeah, I appreciate that, Sean. Yes, it does raise the point.
Can I just add something?
Yeah, go ahead, Jennifer.
I think that is an important distinction that Sean made between the public health leadership and the actual boots on the ground public health of people who are serving. And this based on my experience, and I can't speak for other public health divisions in the country, but where I was sitting, leadership wasn't even talking to us. So when the pandemic started, we were kind of on our own. We would ask questions like, how do we handle this? What do we do? What do we tell these people? Leadership ignored us. They didn't answer our emails. They didn't answer us. They didn't ever come talk to us. Like I asked for daily briefings. Can we have, the situation was rapidly evolving. Every day was like, you could start the day one way and end the day another, with all this totally different, and all this stuff was happening so quickly. And I asked for daily briefings. So we could ask questions on how do we handle this? What do we tell people when they ask this? What do we need to have a unified message. And we got crickets. And that was the biggest problem for me where I was sitting. We were largely ignored. And so as the PhD, as somebody who's a virologist, who's worked in a laboratory, who understands the testing, who I had to help my coworkers, we had to help each other, did you see what the CDC just posted on their website? And they would print it and share it for us. Like, do you understand what this NAAT means? Okay, let me explain that to you. We were having to help each other, and leadership was just ignored us. It was over a month and a half into the pandemic when they finally included us on the daily report. Just an email they had already been sending out for a month and a half. And that was okay, let's just send them this so they have a situational awareness. But I think it's really important to have that distinction between leadership and the people who are actually boots on the ground.
Philip, there was a time. I'm sorry. There was
Go ahead. Finish this point. Yeah.
There was a time in this country when HIV was being used as a political tool. And I remember this is when I entered public health. When I entered public health professionals were not people to mess with. Politicians didn't want to play with them because public health wasn't going to be used. Public health issues were never going to be used for political gains. And so when I started my career in public health, politics and politicians didn't want anything to do with public health professionals because they were scared. It could hurt them rather than help them. And public health professionals, in my opinion, were stronger and they had a backbone. Today, I think they're just kind of going along with the flow because they're afraid of what could happen if they don't.
Well, it leads us right into one of those situations that we have. Now, from my perspective, and this is my perspective, I think that when we don't have a clear origin of this virus, it's a very strong possibility that it wasn't natural. It has capabilities we have never seen before. This was part of the reason why the world was locked down and then they mandated vaccines, okay? We still have this same virus circulating and public health has gone completely silent. It's almost as if it's no big deal now. Don't worry about it. Even though mortality is 12% within 30 days of an infection if somebody over 65 was admitted to hospital. We have a problem here. And it doesn't seem as though anybody has any answers. And when we have that situation where our answers are not there, it seems as though there is silence. Anybody want to take that on? Because we're going to lead this into the question about the vaccine.
Well, Philip, I said this a few years ago. We had this discussion and I said, what did I say? We need to pivot towards treatments. We need to pivot towards treatments. There always should have been a treatment option. When you have a virus, a respiratory virus, a highly mutable RNA virus, you treat it. You have to have some kind of treatment. If you want to stop transmission and you want to stop infection, you have to decrease the viral load in the individual, and that will decrease the viral load on a population level. So pivoting towards antiviral therapeutics and some kind of treatment regimen, that has always been the key. It's always been the key to stopping this.
Thoughts, Sean?
Well, I think, and again, this is where Jennifer, and of course, a lot more than I do, but I think we're dealing with a lot of very, very different populations. We're dealing with vaccinated populations. And when I say vaccinated, they may have received one or two. You're dealing with people who received all the boosters that they possibly could. You're dealing with people who didn't get vaccinated. You're dealing with all ages, up and down and all around. And the reality is I think there's so many there. This is why I value you so much, Philip, too, because There's so many unknowns. I don't necessarily know if we can answer that question. I agree 100% with Jennifer that we do need to pivot, but I think there's many more unknowns than what we do know. I just think a lot of people like to think we're at the end of this. I think we're going to be at the beginning of this. And I think that the silence coming from public health, if you want my honest opinion, is the same type of silence when you know you've messed up. And rather than coming and owning what you've done, you're just pretending it never happened in the first place.
Wow. Yeah, that probably is right. And so then it leads us into where we are now. There are a lot of rumors that HHS is going to stop recommending vaccines to children and pregnant women. Some people think it's going too far. Some people think it's not going far enough. Jennifer, you want to take that on first?
I think Sean is 100% correct. We have this whole spectrum now of people who never took an mRNA injection, who have been infected, who took one, who've been infected, who've took 6, people who've been infected 4 times. So we have such a spectrum now in terms of SARS and immunity and where we're at. And we've never been in this place before. We have never been here before. And I said this before also, the novel thing was never the virus. The novel thing was always the mRNA. And we had no idea what the mRNA was going to do. We still to this day don't have studies we have a global mass experimentation right now on the impact of these mRNA injections on the immune system, on immune health, and on population immunity. And those are kind of studies that should be done. Now, in terms of this recommendation, so what they're saying is they're not removing mRNA vaccines for anyone. They're just not recommending they get them anymore. That doesn't mean they're not available. That doesn't mean that pregnant women aren't going to get them anymore. That doesn't mean that children aren't going to get them. They're still available. They're just not going to push them. Children never needed them. So there are still children getting them. There are infants 6 months old who are recommended to get not 1, but 3 mRNA injections at 6 months old. It's unconscionable to me. It's just unconscionable. And I think that it's come a little too late. And we're now in this position where we don't know the impact that all of what we've done has had. And we don't know what the impact will be on now stopping all of that. So we need information.
Absolutely. Thoughts, Sean?
Phil, if we don't learn from history, which is why I'm so happy you've recorded everything, and I'm hoping that we can look. Let's go back to 1976 with the swine flu vaccine that killed several Americans and actually caused life-altering things in their bodies. This was a vaccine that the government pushed and did very similar things that we saw in COVID. COVID-19, we introduced an mRNA vaccine platform that really had never even made it through any safety clinical trials. Anybody who tells you they have, it just wasn't true. We had tried and it failed. I think it's absolutely reckless to even continue to offer these mRNA vaccines at this point, because we simply cannot answer the question. Number one, is it safe? Number two, is it effective? And number three, does the risk benefit equation lean towards the consumer of the vaccine? So I think it's reckless. I'm glad that they're going to remove it. I don't think it ever should have been on there in the first place, but it confirms exactly my point of how public health is politically influenced, because it wasn't the ACIP that decided to pull these things off the vaccine recommendations. It was a political change, and that political change led to this very important recommendation change and switch. And I think that that's just more evidence that we're politically compromised in this public health system here in the United States. And that's why I would empower everyone to really, as Jennifer had mentioned earlier, become informed and make good decisions based on the information that you gain. Ask around, keep talking. Go ahead, Philip. I'm sorry.
No, finish your point, because I was going to throw something else in. Finish your point on that.
Well, one thing that really always bothered me, Philip, was the mRNA platform was new during COVID. It was a brand new platform. And when we look back in history, I brought up the swine flu vaccine. Let's look at hepatitis B. Hepatitis B was the first recombinant vaccine ever used. It was licensed in the United States in 1986. And in 1991, it became something that was recommended on the list. And I know, look, this is a faux pas topic. Bringing up autism with vaccination is never something you want to do as a public health professional. It could mean death. It's like taboo, which is one of the greatest reasons why I like RFK in his position, because he is allowing people to talk about these taboo topics. And public health just simply saying, well, maybe our surveillance is better, is why autism has increased 312% since the 90s. But look, here's the deal. The average autism case is diagnosed at age 5. In 1991 is when it was recommended that all children within the first 24 hours of their life get vaccinated. In 1996, we had a massive increase in autism diagnosis. Public health must investigate this fairly, openly, ethically, and with integrity to get a true answer. And that's not anti-vaccine speaking. That's just simply someone who champions for the public health. If you benefit from a vaccine, awesome. But if you're injured from a vaccine as a public health professional, I owe it to you to champion for your case too.
You've stepped into a rabbit hole here, Sean. And just to say that Susan Language, I usually use her quote because I think it's so important. That she said, the reason why the standards with a vaccine are different from a therapeutic is that you usually are giving a therapeutic to someone who is sick. With a vaccine, you're giving it to someone who is well to prevent future disease. You cannot afford to make them sick because of the potential future risk of disease. And so this is why vaccines have to be so safe. And so you're right. Anything that raises the issue, say for instance with autism, should be able to be challenged. And so since you've opened this door, let's step into it a moment.
Well, first, Philip, can I say something? Can I say something too?
Yeah, go ahead.
Why are we vaccinating an infant before he's even 24, or she is 24 years old?
100%.
Hepatitis B virus is spread primarily through needle exchanges and risky sexual behavior. Well, I mean, what kind of, seriously, like, you've got to really think here.
You know the answer that you get when you ask that question? Because I've asked that question.
My kid in daycare. Somebody's gonna bite my kid in daycare.
No, they say because the mom could pass it. Let me tell you, the mom is already tested for it. The mom's already been vaccinated. So like that doesn't hold water. But I want to say to Sean's point, you know, making these recommendations again based on politics instead of science. It goes back to what I said. We don't have data. We don't have information. You know, I just had this conversation with a colleague yesterday about vaccines. We don't have any studies on giving flu and COVID shots at the same time. We don't have any studies on giving annual flu shots every year for your life. We don't have any studies on how that impacts your immune system. We don't have any studies on giving look, a baby goes to an office at 2 months old and gets 6 different injections with 23 different antigens all at the same time. We have no studies on that. None whatsoever on the combined effect. The effects of combining vaccines, of combining antigens. There is zero science. There is zero. You can search. I searched the peer review literature. I asked my colleague. She said, because there are no studies. There is nothing out there. We're still making recommendations based on politics and not science. And I think that's why it's so vital what RFK Jr. keeps saying, and he better stand on it, is that we need to do the science. We need to do the studies, regardless of what the outcome is going to be. If it's something we don't like, that's what we need to know. We need to know what the facts and the data says.
Well, here is the question that the public is therefore going to be thinking. How is it that it takes RFK, who is a lawyer, to raise this point? Why did public health not look more closely at what Andrew Wakefield and his team had done? What was the reason that became such a taboo that I cannot even find the paper, even though it was retracted? If I wanted to look at it as a historical reference, I can't find it.
The answer is simple. And this has been the simple answer for how many years now? Money. Money. I've asked these questions when I worked in research. Well, we don't want to lose our funding. Like, all the funding comes from one place, and they're the ones who tell us what research to do. And if we test this drug and it's an outcome that they don't like, then we're not going to get the money. We're not going to ever get money from them ever again.
Is that really how it's working, Sean? Please say something better. So let me ask you this with your question, Phil. What are you getting at? Tell me what you're wanting. Give me. So we have a situation here now, and to be frank with you, I completely agree with you at the point with hepatitis B, because I remember I hadn't put much thought into this vaccine autism thing, even though my sister has worked in that area for a long time. And there was something about when there was an outbreak of pediatric hepatitis, okay? And somebody told me quietly, I have no evidence for this, they just told me quietly that they thought that the reason we had this worldwide outbreak, this was in about 2022, all across the world at the same time, children were getting hepatitis and some died because of it. And she said that she thinks it was because they were catching up with the Hep B shots. So they were then vaccinating as trying to catch up with the shots. And it raised the question in my mind, oh my goodness, I hadn't even thought of the fact that we're giving Hep B to these little kids. What was the logic? At that point, I realized that our system was compromised. And the fact is that even so I'm not criticizing anyone because I fall in the same category. I didn't ask the question. So how do we justify that position, Sean? Well, Philip, I think the first thing we do is do what you just did. We own it. Look, I signed my kids up for a Hep B vaccine when they were little. I had my children vaccinated with little to no question. And really what hit me, Philip, was the first time that I started questioning the mandate. And keep this in mind, that if you are a public health professional, you should have never argued vaccine schedules. That is taboo. If you argue a vaccine schedule as a public health professional, you are seen as kind of an outlier. And so somebody asked me several years ago, Sean, do you think the Pope should get an HPV vaccine? And I chuckled a little bit, but I was conflicted, Philip. I mean, here I am, public health professional. I'm supposed to be pushing this agenda. Yes, of course, everybody should be, but then I thought, wait, the Pope, because of a particular lifestyle, should actually be abstinent. And so if the Pope is abstinent, would the Pope need an HPV vaccine? And what does the risk-benefit equation tell me? And then, and so I became conflicted. And then as a public health professional, I began looking at the schedules and I began looking. And then, of course, COVID happened, the mRNA vaccine. And what I've learned, and I've seen some of the comments, Philip, I have to be honest with you. A lot of people in public health, in my opinion, have become lazy. And what I mean by that is we lean on big pharma to solve our problems. We lean on healthcare to solve our problems, and we're no longer empowering people to make decisions that are best for themselves and their families and doing things holistically and for themselves to stay healthy. And it's important to remind people that big pharma and healthcare, they're businesses. They make money off of people being unhealthy. And the saddest part is that public health should not be in bed with them. Public health should be independent of them and should be encouraging people to do what's best for themselves and their families at all times. These are hard discussions, and challenging. But go ahead, Jennifer. You wanted to say something.
Yes, because the reason that I was discharged from my position for the good of the service was a post I made on LinkedIn. And speaking of integrity, I stand by what I said then, and I stand by what I said. What I said is that public health professionals need to stop pandering to politicians and to the media. And that's why they fired me.
Mm. That is serious, because so the expectation then is that following the narrative is more important than the truth. And truthfully, I think I've come across this myself, because when I do challenge much of the science, a lot of people are saying that you're damaging the integrity of medicine by challenging it. And I'm saying that
Yes.
fundamentally, our job is not to protect the integrity of the profession as much as it is to protect the patient that we should be advocating for.
I
And
mean,
so
exactly. I'm a scientist. My training is to question everything. That's my training, to be skeptical. Like, this is data. Okay, well, what does that mean? This is dogma. Question the dogma. That's my training, is to question it. And I questioned it. And what makes me angry, let me tell you why I'm so angry at my anniversary of being fired. And I think you talked about this journal article that came out about the deaths in Greece and how the deaths were being misclassified. Almost 50% of the deaths. And I wrote a Substack about this as well, because I think I'd just been marinating on this, because that's why I was fired. I called out the fraud of the deaths. I called out the misclassification of this COVID. Everything was a COVID death. No, it wasn't. And that's why I was fired, because I called it out. And I called out the fraud. And I said, this is not really a COVID death. Why are you calling it a COVID death? Our role in the situation we were in as public health professionals, it was so important that we get it right. It was so important to get it right, to do the right thing. And instead, they just pandered to the politicians and what they wanted. And they pandered to the media and told them what they wanted to hear. And that was too much for me. I couldn't sit there any longer and stay quiet.
Jennifer,
Go ahead, Sean.
Well, Jennifer, as a virologist, I had a chance to work a lot with her. And one of the biggest things, you brought up earlier, there's no natural host for this virus. And, you'd also asked the question, why are public health professionals so quiet? Well, the honest regard to it is, I truly believe, and if you're following the news right now in the United States, you'll know there's a pause on all gain of function research. That was an executive order that was signed by President Trump. And that is an indicator to me that we're headed in the right direction, because I do believe with all my heart, this was a man-made or human-made virus. In fact, I would argue that it's human-made in the United States and shipped overseas. And unfortunately was something that was so novel that did get out of a particular containment facility and cause a worldwide pandemic. And I think there is no evidence, in my opinion, that I've seen that's contrary to that discussion point, Philip. And that may be another reason why a lot of people are staying away from this topic. It's a taboo in this administration, as odd as it is, and it is RFK's point. As odd as it is, the reality is that they are talking about issues that have not been talked about, that need to be discussed, and science needs to be the determining factor on whether or not it's true.
Now, since you have touched on that point, because for me, that is a very, very serious point. It's serious from a clinical perspective. It's serious from a public health perspective. Because in effect, if that is the case, let's just say for a moment that we don't know absolutely. If this is the case, that this was lab engineered, it must indicate that the potential of the virus is way beyond anything that we have ever seen with any other normal virus. Bacteriophage capabilities, damage to the immune system. Is there a responsibility from public health to be on the highest alert about that, rather than where we are, where it's almost an assumption that everything is okay?
Well, can I
go ahead,
that, because I have to disagree with Sean.
The
virus did not cause the pandemic. The response is what caused this pandemic.
We agree,
the
Jennifer.
Policies were the problem the whole time. It wasn't the virus. And yes, I know you have a different perspective because, Phil, because you see people in the clinic. And yes, this virus does some very interesting things, and the damage that it does and how it interacts with so many different cell types. It is, to me, I've never questioned that it came from the lab, never doubted at all that it came from the lab. Having managed biocontainment facilities, having worked with viruses, having done gain of function, I've done all of that. So I had no doubt that it came from the laboratory, but the policy was what the problem was. And I've said this over and over, that the response, all the response did was prolong it, make it far worse. 100%.
Jennifer, we're not in disagreement. 100%. The origin of this virus is human made. I'm 99.9% convinced of that. I have been for a long time. Jennifer and I have talked about it, but you're right, Jennifer, it got far worse because of the decisions and the public health lack of leadership as a result of how they responded to this.
So I've heard that there's going to be, well, I've heard there's discussion of a shift for CDC, and that they, so there's actually three areas of public health. The two main ones let's talk about is surveillance. So that's the epidemiology portion where we collect data and do surveillance. And then there's the policy arm. So the people who are deciding the policy shouldn't also be collecting the data. It's again like the tire shop. If the tire shop's throwing nails out on the street, then they're coming and fixing your tire. So we need to separate the data collectors from the policymakers. And I've heard that there may be, I don't know if it's a rumor, but it seems like to me that would be a great idea, is we need to separate those two arms and not have them influence one another. Like, they should look at the data, and the data should inform policy, but the policy shouldn't tell what data to collect, if that makes sense.
Yeah, but it therefore still raises the question, if this is the case, and this virus is far worse than anything that we have seen before, why are we presuming that everything is now okay? As I say to people, HIV is a mild infection when you get it. It doesn't mean HIV is mild. In the same way, the fact that this infection now appears to be mild without severe respiratory compromise, why is it that public health is therefore taking the view that this is no longer a problem?
Oh, Philip, like I said, I'm not so sure that public health has that stand or that point. I really truly believe at this point, because there's been a huge, at least in the U.S., there's been a huge administration shift. There are lots of things up in the air. And I think that people are still trying to understand where we're going and what we're doing, and not only in public health in the United States, but also related to this topic you're bringing up.
Well, I don't think I can speak for Hawaii, because that's where my experience is. They still have the COVID dashboard. They still count cases. They still recommend the mRNA injection. So as far as I know, in Hawaii, it's still rolling on.
Yeah, so these are some pretty big topics, and I one of the things that I think stood out in what you had said, Sean, is the fact that we are now in a very multi-layered population situation. People who've had multiple boosters, people who haven't had multiple boosters, people who have had one, people who have had two, people who have not been unvaccinated. I'm going to say something here now, and I want you to think about it from a public health point of view. I did some research on the Office of National Statistics data. Now, I'm not a statistician. However, I did find a period of time where the numbers had stabilized about 6 months. And when I looked at those numbers for people who had one injection and didn't have any more, people who had two injections didn't have any more, it appeared that there was a higher mortality from non-COVID causes, almost double for people who had one, and then a little less for people who had two compared to the unvaccinated cohort. What we may be facing is a situation where there is differential risk across the population. How can it be right that public health does not know who they need to target to support?
That's a really good question.
Again, I think I think it's just so entrenched. The thinking is so entrenched, and the hooks have gotten so deep that they don't see anything else. They don't see anything else. I was actually reading a Substack from someone who's an epidemiologist, a Yale professor epidemiologist. She writes Your Local Epidemiologist. And I was shocked. I was seeing some of these blogs about mRNA and getting your updated booster. And I was like mortified. I'm like, so I messaged her. She never responded to me. Never responded to me. It's like, this is the thing. Like, yes, vaccines can be good, but they can also be harmful. And we need to acknowledge that. Not every product is good for every person. Not everybody needs to take a blood pressure med. Not everybody needs to take cholesterol medications. It's not an across the board, everybody is the same. Every human is unique. We are uniquely created by our creator. Every human is different. And we can't have this blanket recommendation for every single human being.
Yeah, I think that this is an important point, is that we do need to have the nuances coming back. And I don't know how this is going to occur, because there seems to be such a poor understanding of the science around COVID, and everybody seems to be willing to just move on and leave it behind when it's not gone. And so we are in a very, to me, actually, I think we are in a more serious situation now than we were in 2020. Yes. And when I did the Greek numbers and looked at the numbers, their mortality is still higher than the average between 2015 and 2019. It is still going up. So this is what I mean, is that we need far more than just sound bites now. People are still dying in high numbers and getting sick.
Philip,
where is public health? Yeah.
It just goes back to what I said about we don't have the research. We don't have the science. We haven't done the studies. We are just, we're just flying by the seat of our pants, apparently. We need to do the studies. We need to look at this. And I think, some of it's what's come out, and I don't know how deep you want to go into this with, we talked about IgG4 in the past and immune tolerance. And that's something I've been kind of thinking a lot about, is how have these injections, how have the mRNA impacted the immune system? How has it impacted population immunity? And I think, we're seeing a lot of viral infections. We're seeing RSV infection, monkeypox infection, measles outbreaks. We're seeing way more viral infections, and not just more different infections, but the burden is higher. We looked at this last flu season. Oh, it was far worse than it's been in the past. And why is that? And why are we not asking the questions? Why are we not willing to say, could it be the elephant in the room? Could we have really done something to affect the human immune system, the population immune system, global immunity in a way that has negatively impacted us? You've had Christine Stable-Ben on, and I love her work because she talks about off-target effects. And what does that mean? What are the effects of vaccines and all of these injections on overall health? And those are such important questions. That is the key work that we need to be doing. That's the key research we need to be funding.
Philip, I also, I'm not giving up here. I think that the questions and the issues that you've brought up, I think, are things that this public health administration may begin to tackle and may begin to address and look at. Am I hopeful? I'm hopeful. Do I know it'll happen? I'm not sure. But I think that, again, public health today is, at least in the United States, is in a shock mode. Almost every public health agency has had a vast reduction of workforce. We have a leader now that is asking questions that used to be completely off the limits with public health. So there's change there. And again, to me, I agree that with COVID, we have so many unanswered questions, but I also believe that there are people that do want to move on. Hence, and let's bring back politics. Tell me why President Biden pardoned Dr. Tony Fauci. Come on. I mean, these are issues we've got. If we're going to answer questions in public health, let's start there. I mean, we've got to really, truly start taking a look at the questions that should be answered to get the truth and transparency for the general public. So
yeah, that one is a hard one because, as I say, from a medical point of view, Tony Fauci, he was involved in the writing of one of our important textbooks, so one of the early chapters on microbiology and so on. So he is, in a sense, a hero of medicine. And to think that, I mean, this is part of the reason why I think that the medical community just cannot get their head around that reality, that fact that stuff was being done here that shouldn't have been done, and the people that we least expected to be involved were involved. That is a huge hit to credibility. And so I think that certainly the community would be happy if this just moved on. It's kind of like, when the police may have shot somebody and they shouldn't have. If it could go away quietly, that would be better for the for the credibility, But yes,
I think
this
it's
is a
hard
big
for
one.
people. I think it's really hard for people to accept that they were lied to. I think it's hard for people to accept that they were bamboozled, they were scammed. That's a really hard thing as a human being to come to terms with. And it's easier just to ignore it and continue believing what you believe. I want to say, in terms of leadership, I think that we do have new leadership. And in my opinion, being a good leader means sometimes you have to be controversial. You have to say the hard things. You have to do the hard things, and not everyone's going to like you. And you have to be okay with that. Knowing that at the end of the day that you are doing the right thing. And we have an opportunity now with these people who've been put in these high-level positions at FDA and NIH and HHS is to shake things up. We need to shake things up because we need things to change. Things have to change. We cannot keep going the way that
revolutionize.
Yes, it's time. It's way past time.
Yeah, I agree.
So we have that opportunity now, and I think there is hope, but there's also a lot of skepticism still. So my colleagues say, I just thought things would change, and now I don't know. There's someone who's been put in charge of NIAID, Jeffrey Taubenberger, and there's a lot of discussion about him as a controversial pick because he was the one who resurrected the 1918 influenza virus from frozen samples. And so he's like the father of gain of function research. If you want to talk about dangerous, what he did was very dangerous and shouldn't have been done. And now he's in charge of NIAID. And is he going to follow in the footsteps of Fauci? There's a lot of people who are very upset about that decision. So, we have an opportunity and people are watching. And I think that's where you mentioned at the start, can it go too far? People are watching. Everybody is watching. And you better believe that the second something goes too far, people are going to say it. People are going to speak up and say,
Dr. Phillip,
has gone too far.
Dr. Phil, I'm looking at comments, and I usually don't want to address them, but I do have to. In
Tell me which comment you want to pull up.
And it's not in defense of Trump. The time Trump started it, it's not in defense of Trump. If you do research, you'll see that the first gain of function moratorium occurred under President Obama, and it was a good decision. He stopped gain of function research under President Obama when he learned that there was gain of function research with coronaviruses using technologies that allowed for the cover up of genetically modified viruses. And President Obama put a gain of function stop on it. And that work was shipped overseas during his presidency to overseas labs that included Wuhan, China. So people are saying you're right. COVID started under Trump, no doubt. But the gain of function research that started all of this was years before his administration.
I suspect that what they're making reference to is that the warp speed with
the
regard
vaccine.
to the vaccines started under Trump. And so, in a sense, the argument from much of the public, especially because he hasn't come out against them and he's still supporting the development of mRNA technology, I think that this is where he is now caught in the middle, so to speak, with regards to what has happened. Now, and in truth, my position is that, as I've always said, I don't know as yet if mRNA has value as a vaccine. And hear me out, hear me out, hear me out. The reason I say that is because I strongly stand the ground, because it's not just mRNA that failed against COVID. Every single type of vaccine failed against COVID. Whole virus, adenovirus, protein base. I guess they had some better. So the problem, as I said, was the disease. They just picked the wrong disease. Now, with that in mind, and believe me, I know the limitations with regards to the cellular impacts and so on. However, my question is now where we are with the plans to remove vaccines or remove the caution on it, they have not replaced it with anything else. Is that dangerous?
Well, I think what you're saying is correct. They picked the wrong disease. But when we talk about respiratory viruses, Philip, it's the route of inoculation is very important. And that goes to all of the studies I did as a postdoc, where I actually compared intramuscular injection versus intranasal inoculation and even small droplet aerosols, and looked at how that protects against virus infection. And when you talk about giving an intramuscular injection, you give something here for something that infects you here. You're not going to get the same level of protection as if you inoculate here in the nose, because you're getting stimulating local immunity, which is where the virus enters. So route of infection, route of inoculation is very key. Again, not every virus is amenable to vaccination. Not every platform is going to work for every virus. And that's why you spend years studying up front what's going to be the best preventative for this. At the same time, you also have to have that other arm, which is the therapeutics. You can't ignore that. You can never ignore therapeutics. And that is a problem. That is very dangerous. And that's why I said that before. We should have pivoted long ago to looking at therapy. There are doctors, we know FLCCC, we know, there's a group in Canada, we know Dr. Shetty, we know there are all these doctors who have protocols. And they've also all said that sometimes you have to look at the individual patient and what's best for that individual patient. So it is very nuanced and it is complicated, and we shouldn't shy away from that just because it's complicated.
Philip, what got me thinking about recombinant vaccines, the flu vaccine, hepatitis B vaccine, what got me thinking about that was the lessons that we seem to be learning about the challenges from the mRNA vaccine. I believe the platform of delivery of vaccine could be causing problems. That's my belief. You go back in history, the natural aspect of vaccines and how vaccines were used as a strategy. The shift to recombinant vaccines, in my opinion, has led to something that public health does need to investigate. That platform may have caused something that public health should investigate. And the mRNA platform, which is, again, a new platform of delivering vaccines, I believe is causing problems as well. I think it isn't the actual vaccine. I think it's the mechanism of delivery, the platform of the vaccine that could be causing some of these problems.
But it's not a vaccine. It's gene therapy.
That's
the problem. It's not.
I call it a shot, Jennifer. I don't like it either.
I can't. It's like it bothers me that we're using that word with mRNA because it's not a vaccine, and that's why I have such a problem. I know this is going to get us in trouble, Philip, but I have such a problem. I've worked in vaccine development, and just inducing any kind of immune response doesn't make something a vaccine.
Well, that's not what CDC says, Jennifer. CDC
that
says
that is just such a fallacy that we need to start with, is that a bee sting produces an immune response. Does that mean it's a vaccine?
There you go.
No, we need to be very careful about how we discuss these things. And I've commented before on your Substack too. It's like, we need to stop with the misnomer. That's confusing so many people. It's not a vaccine.
Yeah, so this is actually, you make a very good point. And to be frank with you, if you'd seen the comments, a lot of people were saying the same thing, stop calling. so you are correct. But because the how do I say this now? In order for you to even get past the narrative, if you call it a shot or a jab or gene therapy,
but I've told people for years. I worked with flu. That's my bread and butter. Like, I'm an influenza virus expert, and I worked with flu and flu vaccines. And I told people for years, I don't even call it a vaccine either. It's a flu shot. It's a shot. It's an immune booster. That's what I would explain to them. It gives you immunity for a very brief period of time. And that's why you have to keep getting it year after year after year, because it's not long lasting. But the other thing is, we don't even know. We don't even know how it programs immunity long term. So, like, I never even called the flu shot a vaccine. It's not a vaccine.
It hasn't earned its title.
You cannot vaccinate, if you want to use true vaccination, against a highly mutable RNA virus. You just can't. You simply cannot. The virus is too fast, and it's just too fast. You can't beat nature. My virology friend and I, we have this discussion. It's like a dog chasing a car. You're never going to catch it. You're never going to catch it. You can predict all you want. You can model all you want, but nature's always going to beat you. It's just always going to be smarter.
I think that's something that needs to be said, Jennifer. And actually, I'm highlighting it because this is what is causing a lot of the confusion. If you call influenza a vaccine, then you also have to, therefore, in a sense, label COVID a vaccine. But you are absolutely right. And I have argued this point to people. I said that the loss of trust in vaccines is because that differentiation has not been made to the public. And so, therefore, their perception is that a TB vaccine or an MMR vaccine is equivalent in efficacy to to a COVID or flu vaccine.
Philip, when I was going through graduate school, the definition of a vaccine was very, very different. Instead of being pro-pharma, it was actually pro-consumer. And it was very clear what made a vaccine. Number one, was it safe? Number two, did the risk-benefit equation favor the consumer? And number three, did it work? If it didn't meet those three criteria, it was not called a vaccine, because at that point, vaccines were the gold standard of public health. And all of a sudden, it comes limping in the flu vaccine, which is, well, maybe you'll get sick, maybe you won't, maybe it'll shorten the time, maybe it doesn't, maybe it matches, maybe it won't.
That's what I would tell people.
It's like, that doesn't deserve, it's like calling a Yugo a Cadillac. You can't, it's just not, a vaccine is safe, it's effective, and in my opinion, it is. And it benefits the consumer, not the producer.
I have to disagree, because a vaccine, by definition, should prevent infection. This is what we want. It's a preventive. It's by definition a preventive.
But you don't lose your life.
And that's what I would tell people with the flu shot. Why do we give it at the beginning of the flu season? Okay, October, flu season starts before winter. It's because we know it'll give you some benefit. It will decrease the length and severity of disease. That's what I always tell people as somebody who works in that field. And I have to go back to my point again. Nothing can ever be safe. You cannot ever test safety. It's toxicity. Toxicity is a spectrum. What's toxic for you may not be toxic for me. What's toxic for somebody else may be not. There's a guy in Germany who supposedly got 217 mRNA injections and supposedly still alive. I don't know, has anyone checked on him lately? But what may affect one person, again, going back to, we are all unique individuals. What I've never had strep throat. strep doesn't bother me. I've never gotten strep throat. Other people get strep throat every year. So we are all unique. We are all uniquely created. And what affects one person one way may not affect another person another way. And yes, that makes it very difficult to study. It makes it because there's so many confounders, right? So how can we say? And we have to acknowledge, it goes back to your point, Philip, we have to acknowledge that people were damaged. People were damaged. People have been disabled. People did die from these mRNA injections. And why is that such a bad thing to say? Why is that such a bad thing to say? We have to admit there is toxicity. There's always going to be toxicity. Well, and that's what I think is very important, is people need to understand what is the spectrum? Who is more risk for those toxic events?
Well, I'd like to make the point here, because I do feel very strongly about this, that one of the reasons why I will call out the public health industry is that they were involved in the mandating. And if they believed it at the time, okay, you believe that. However, to have mandated a vaccine and to ignore or sideline people who have been injured and not even make the attempt to understand the science as to why they were injured indicates to me that those people should not be in a position of leadership. And I will say that quite openly to anybody.
This is not the first time this has happened. If you look at HIV and what happened with HIV, and you want to bring up Tony Fauci and what he did to people with HIV. And, we can talk about Lyme disease and how that was ignored and that was all in your head and that's not a real thing. Like, this is not the first time this has happened. There's a history of this. There's a history of this in public health.
Philip, what broke my heart with what you said is I agree with every word you said, with one exception. I really, truly don't believe it was the public health industry or the public health workforce. I believe it was the public health leadership. I think they're bought with an agenda, and I think it comes with money and politics, and the rest of us are just trying to do our jobs under. I mean, everything you said, and we've been in the trenches. Jennifer and I have been in the trenches with you from the very beginning, and we have resisted everything that's happened. We are public health professionals. It was poor public health leadership. And I agree with everything you said. I just wish we could add a leader to that, because I really do believe there's great public health people out there that didn't believe in this, didn't buy into it, and really wanted something different for the people they were serving.
I think this is a wonderful discussion. And I can see from some of the comments that people wish we could have had this open discussion in the past. Yeah. It's sad, and we couldn't because of censorship.
Yeah.
But as we come to the close here, I want you guys to think carefully now and just imagine for a second that RFK or his team are able to look at what we've been discussing. What would you want to say to them in terms of the future direction that public health and health generally needs to take? Jennifer, you go first.
Oh, put me on the spot. Yeah. Wow, there's so much. There's just so much work that needs to be done on so many different fronts. And targeting public health, when I think about public health and CDC, I think there does need to be an uncoupling of the money from the policy. I think that policymakers need to be they need to be vetted, and they need to, like RFK Jr. himself is not in bed with pharma companies. He's sued pharmaceutical companies. So we really need to uncouple money from those decision-making. I also think that we need to put public back into public health. So, from my experience sitting in an office behind a computer, that's not public health. You need to get out in the public, interact with the public, educate the public. What are their concerns? What are they wanting information about? Education, public health education, getting out there, building relationships in the public, That's very important. And that way, when these kind of events do occur, you already have those established relationships with the stakeholders. And I think that's more important in terms of influencing them to make decisions and be able to pass on the information that may need to make decisions. So, I mean, there's so much more I can say, but I think going back to basics, basically, just get back to basics.
Excellent. And Sean?
Philip, thank you for the question. I think it's important. And I think if anybody is listening from RFK's team, there are three things that I think we need in public health. The first thing we need is full transparency. We need everything that is out there to be presented in a manner that people can understand, people can read, people can see the truth, because that's my second thing. We need transparency. We need absolute truth. We don't need agendas. We don't need to make businesses healthier. We don't need to play political games. This is our life, our livelihoods, the quality of our life. We need complete transparency. We need truth. And last but not least, which is clearly evident, you said it about doctors earlier, and I'm sure public health is even worse at this point, we need to foster trust again. We need to start championing everybody. Look, we don't just serve one side of politics. We don't just serve those who benefited from a shot or a vaccine. We serve everyone, both sides of the aisle, those who were injured, those who were successful. We provide information to people, empower them to do what's best for them, and we support them in every way we can. And if you're out there listening, I tell you what, truth, transparency, and trust, that should be the focus of public health over the next 4 years.
Wonderful.
I think I like exactly this quote. RFK said this during a hearing recently with the budget hearing. There aren't Democrat children and Republican children. They're just children. And it goes for us as well. You know, yeah, we may have some political leanings, but we are all stakeholders. We're all stakeholders in this.
Excellent. Excellent. As usual, it has been wonderful and inspiring talking to you all. I think that this is a good point where people can see honest, open discussions with a willingness to acknowledge what we know, what we don't know, what was right, what was wrong, and where we can pivot to for the future. This is what we hope for in the years to come. But we will see. We wish RFK all the best in his work. I would encourage him to make sure he has good people around him, people who have integrity, and people who are not afraid to standing up for what is right, even if it goes against the narrative, whatever that narrative may be. So thank you both. Wonderful having with you. I'd like you to wait with me until after the outro, but have a great evening.
Thank you, Philip.
Thank you, Philip.
Thank you, everyone.